Thank you for joining us for our point of care ultrasound in hypotensive shock and cardiac arrest lecture. Hopefully this will provide physicians and practitioners some background as to some effective ways that they can utilize ultrasound at the bedside of patients in critical condition to help drive their decision making and even evaluate how efficient CPR is and other things that can be very useful in making those immediate decisions necessary in critical care. Our objectives for today are to look at goal-directed echo along with other expanded exams such as shock and brush exams that can provide life-saving physician guidance in critical situations. We're also going to look at how these approaches can be utilized to further evaluate hypotensive shock and cardiac arrest, and evaluate how the transesophageal echo evaluation can be utilized to direct chest compressions to the site of maximal impulse, which will improve CPR outcomes in the most critical patients. So first of all, we need to look at why we use ultrasound. So we know, as in other utilizations of ultrasound, that it is rapid. When you're utilizing this at the bedside of a critical care patient, you can get your results immediately rather than waiting for a patient to go down to another department, get their evaluation, wait for the read, and all of those different aspects. So we also know that this is a relatively cheap approach and that it can be very effective and monitors response to treatment in real time, helping to drive the decision making of the physician. Now, some of the components that we're going to look at today are looking at the left ventricular size and function to demonstrate how well that heart is pumping blood, checking into the right ventricular size and function, as well as looking for pericardial effusions, tamponade, and intravascular volume status, as well as gross valvular abnormality identification. So one of the protocols that we're going to talk about is the basic GDE, or goal-directed echocardiography. Now, the GDE is going to have very similar views to a general echo, but it's going to look at some of the detail in less depth, just because you're looking for specific goals to either count in pathologies or count out pathologies in a very rapid environment. So the general GDE is going to include 5 standard assessments: the parasternal long axis view, or the PLAX, where you're going to be evaluating basically the left outflow tract, the left ventricle, and that mitral valve, as well as the parasternal short axis at the mid-ventricular level. This is where you're going to be looking at that left ventricle, all the walls around the ventricle, assessing how efficiently they are contracting. Then you can go over to the patient's left side and evaluate for the apical 4-chamber view, and this is where you can see all 4 chambers, the mitral and the tricuspid valves, and assess it right in that region, and look for how efficiently those chambers are pumping and what the ejection fraction is, if you so intend. Then we can have the subcostal 4-chamber view, which is going to be completed right at the inferior area to the xiphoid process. This is a great view when somebody is maybe having chest compressions because of the ease of access to this area. And then there's also that subcostal IVC view, where you can look and see how well that IVC is able to drain into the right atria. You're looking for dilatation or size variations in the IVC view here. So now this GDE protocol can be extended to incorporate additional images that include things like organ examinations, evaluation of the lung, additional images of the heart, evaluation of the liver, IVC, thorax, peritoneum, kidneys, and lower extremities. When you start adding in these additional images to your GDE, they can fall into a couple different categories called the Rapid Ultrasound in Shock Protocol, or RUSH, and the Sonography in Hypotensive and Cardiac Arrest Protocol, as in SHOC. So here we're going to start out by looking at that goal-directed echo. So the goal-directed echo, you're typically going to have your patient in a left lateral decubitus position if possible. That's going to put their heart in easier access so that you can scan just to the left of their sternum at about the 3rd or 4th intercostal space. Now, if your patient has COPD or other pathologies in which their thoracic region is going to be lengthened, then you might have to move down to maybe the 4th or 5th intercostal space. You're also going to be important that you're utilizing a phased array small footprint transducer with only about a 5 megahertz frequency. Any higher frequency than this, you're not going to get the adequate penetration. Another important consideration is that you need to make sure that you have the appropriate software package on your equipment to be able to assess this accurately. So once you have all those things in place, you're going to access this parasternal long axis view that we see over here in our right upper corner here. You're going to get that through the region of the window right here represented by this green square. It will look something like this. So what we're seeing here is you're seeing the left ventricle, the right ventricle, the interventricular septum, the aortic valve feeding into the aorta, and then you're going to see a bit of the mitral valve here and the right atrium here. And so with this image, you can really assess that interventricular septum in the upper margin. You're also going to be able to evaluate for that mitral function. If you add color to this image, you can even identify some sort of mitral regurgitation, and you're able to evaluate your blood moving out of that left ventricle through the aortic valve into the left ventricular outflow tract or aorta. And so sometimes you'll be able to identify some significant pathology on that aortic valve as well in this view. You're also able to watch the contraction of that wall and identify if you have any major defects in the contractive ability of both the septum and of the posterior left ventricular wall there. Now, the ventricle is noted anterior to the right ventricle is noted anterior to the left ventricle in this case. Some of the other things that we are going to be able to look at here would be the pericardium. So the pericardium and obviously would be this echogenic outer lining here at the external portion of the cardiac muscle. And then in this view, you could also identify if there happened to be a pericardial effusion. Adding color to there also will allow you to demonstrate that mitral valve regurgitation. It can help you identify any intraventricular defects in this upper region of that intraventricular septum. And so it can give you a lot of information. However, when you're first using this, utilizing color can be almost overwhelming to the eyes because there's so much flow in this region. What you're looking for is little spurts of flow that are a different color than the rest, and that would help you identify that there is maybe a stenotic event or regurgitation or something like that. You can always utilize your pulse wave to put into those areas where you see that elevation in color, and that can help you evaluate the velocity changes in those regions as well. Now, each step you go farther into this makes it less and less goal-directed, so most physicians are going to use this on a very basic level. If they want that additional information, then they'd be referred on for a full echo. The next image you're going to want to obtain, you're going to do here at the same window. So you're going to stay in this green region here. And what you're going to do is turn your transducer 90 degrees. And as you turn that transducer 90 degrees, you're going to see a parasternal short axis view. Now, in this parasternal short axis view, you're going to take a number of different levels of information. So you can start out here at the superior heart. So your image here that you're seeing at the superior heart is going to demonstrate a transverse image of the aortic valve, the right ventricle, the pulmonary artery, the left atria, and the right atria. And so you're going to be able to see that tricuspid valve here, and you're going to really be able to evaluate the three valves, or excuse me, the tricuspid valve of the aortic valve here. Now, as you move, you can also add color here. You can look for any regurgitation or stenosis of these different valves. You can evaluate that aortic valve function. You can put your M mode or your pulse wave through here looking for any peaks and velocities indicating stenosis. So here is what you're going to see with your right ventricular outflow tract here, aortic valve here, and then your right atria in this region. Now, if you, in the same Angle, if you start to angle your transducer inferiorly, you're going to be cutting the heart a little bit lower. So here you're going to see that you're seeing a cross section of the right ventricle and then a cross section of the left ventricle at the level of the mitral valves. So here's where you can really assess those mitral valves. It should almost look like a fish mouth opening and closing, demonstrating that, that motion. Your next image is going to be a little bit lower. So again, you're just going to angle your transducer more inferiorly to the patient's left splenic area. And here you're going to pick up more of the right ventricle, and then we're going to be evaluating the left ventricle here at the muscular level. So in this, you should see symmetric papillary muscles, and evaluate, and you're able to evaluate the function of that whole left ventricular wall. As you go a little bit lower, you're going to take one final image, which I don't have on this particular slide, but of the very apical area of the heart, and this will show you just the left ventricular apex, where you're going to see it almost looking like a donut. Now, as you're following this left ventricle from the superior to the inferior regions, what you really want to do is make sure that the whole muscle is contracting in unison. This can be a difficult challenge because we know that the heart is contracting. If this patient had had a myocardial infarction and one part of their heart is not functioning as well as the other, it's still going to be drug along with the rest of the muscle contracting it. So what you're really looking for is that that muscular contraction is symmetrical and that you're seeing thickening of that cardiac muscle in the whole circumference of the heart. If there's an area that's just being drug along, of course, that's going to be affecting the cardiac function overall, and you won't see that particular area thickening during those muscle contractions as much as the rest of the area around it. So from there, you're going to move to, I have just a little bit more detail on those short axis view findings. So at that pulmonary artery level, you are going to be evaluating the pulmonary valve, the main pulmonary artery in the ascending aorta. At the atrioventricular level, you are going to start from the top, angle down slightly, and here's where you're going to see your aortic valve, right atrium, left atrium, and right ventricular outflow tract. If you tilt your transducer inferiorly into the left a little bit more, this is where you're going to see that mitral valve level that I mentioned looks like a fish mouth as you see that mitral valve opening and closing. And then as you tilt a little bit more, you're going to find those papillary muscles, make sure that they look nice and symmetric, and evaluate all the myocardial segments to make sure nothing's being pulled along, but that the whole ventricle is contracting at this level. And then at that apical level, that's where you're going to see the donut sign. One of the things in this region that you may find is a left ventricular thrombus if there happens to be some stasis from poor cardiac contraction. This would be a general region where you might find that. And here's just a presentation of those particular views again. Here is our most superior view where you're seeing that pulmonary artery, the aorta, and the right ventricle here. Now, if you go a little bit lower, that's when we're picking up more of just that aortic valve with all three of its cusps. Then here we have our mitral valve with our fish lips. And then here we have our papillary muscles, and you'll be evaluating as you go down that heart, and then include one more image of just the apical region that looks like a donut. Now from here, you can typically move to your patient's left lower quadrant of their thorax, and you're going to access the four-chamber heart from this view. So you can see the practitioner here is scanning at that inferior margin of the thorax, and they're going to be angling up into the chest. So the apical window is utilized to assess the four-chamber view, which is always included. If you have the time or the desire or the ability, you can go on to assess the five-chamber view, which would include the four chambers of the heart plus the left ventricular outflow tract. The two-chamber view, which would demonstrate the left ventricle in a different axis, And then the 3-chamber view, which also helps to evaluate the aortic valve. So when we look at the 4-chamber view, here's a nice 4-chamber view. Here we see here, you can see the left ventricular apex, you can see the mitral valve, the left atria, the right ventricle, the interventricular septum, and the intraatrial septum. Now this is a great image where you can really assess the right and left ventricular systolic function. If you have the software packages on your equipment, you can either do, you can even do an ejection fraction where you're going to be measuring basically the lumen of that left ventricle during diastole, and then freezing it again and measuring during systole to see how effective it is ejecting blood from that area. So that is one option that you can do, again, if you have the software package. If you don't have that, at least you're getting an evaluation. You can look and see if there's any pericardial effusion. You can assess and see that the muscle and evaluate if it's all contracting or if some parts are being drug along. So it's still a really good view, even if you don't have the software package that might give you those specific details of ejection fraction. From here, you can, if so desired, turn to a 2-chamber view. So you would rotate 90 degrees here from the 4-chamber view and sweep into the left ventricle. And here's a 2-chamber view. So you're going to see this is basically looking at the left ventricle in coronal, and now here it would be in sagittal. So here we see the left ventricle, the left atria. If you're doing a true ejection fraction, you'd also take measurements in this sagittal view, as that would complete the calculation for your ejection fraction. And again, where here you're evaluating the interventricular septum and the lateral wall, here you're going to be evaluating the anterior wall and the posterior wall. So this is a very effective evaluation if you want to include it in your protocol. Now we also see the mitral valve, so anything that you may not have seen earlier in that parasternal view, you may pick up here. Now just by rotating from this 2-chamber view to about 30 degrees counterclockwise, you'll identify the left ventricular outflow tract. So this is similar to what you were looking at in that parasternal view, just allows you an additional image of that aortic area. Okay. And then an optional apical view would be where you have a 4-chamber view, and then you're going to angle your transducer anteriorly in the patient's body, and that will allow you to open up the aortic valve and the left ventricular outflow tract area here, giving you another view of that aortic valve, its function, looking for regurgitation or things like that. Okay, and then you can move from there to the subcostal window. Now, this is probably the easiest window to assess, especially if you have a patient that's in very critical condition that you're just trying to take a quick look without being too invasive, and yet still this allows you to be able to make some very important diagnoses. So with the subcostal window, you access this from just inferior to the xiphoid process. You're going to have to significantly angle up into the chest, especially if your patient has a larger body habitus. That can make it a little bit more challenging because everything is being pushed up towards the thorax. So, so definitely be prepared to get some pressure in order to get this view and really wedge yourself under the xiphoid area. It's easy access. Now, one of the biggest things or the easiest things that you can find in this image, and that turns out to be typically very high yield, is that this is an area where you would definitely identify pericardial effusions and tamponade. So you can do a quick assessment of the 4-chamber heart, although it's not going to be as accurate as it would be in the apical view. You can kind of look for the function of the cardiac muscle, although again, it's not going to be as efficient as your apical view. And yet, if the patient's in a critical situation, you can get a lot of information just by watching those walls and looking for the pericardial effusion. So here you can see the 4-chamber view. If you have your hand in your transducer in transverse to the patient and you angle upward, you'll get a view like this, the 4-chamber view. And then if you wanted to turn your hand 90 degrees, you can scan all the way down the heart and get similar images that you got into that parasternal short axis view. So again, useful, easy, but just not quite as accurate as the other more invasive views. Now from this window 2, if you take your transducer and you rotate 90 degrees, you should see that IVC entering into the right atrium posterior to the liver here. And so you can evaluate the diameter of that IVC to see if it's effectively able to empty into the right atrium, or if there's some sort of congestion in that right heart that's preventing it from emptying, or perhaps the cardiac arrest is causing that venous blood to pool in that region. So this is an easy area to evaluate, and you can measure the IVC maximal diameter and respiratory variation just distal to the hepatic veins. So right in here is where you're seeing the hepatic veins dump into the IVC. So if you wanted to measure in here, that would give you, demonstrate exactly the dilatation of the IVC. Now here is an image that this is the 4-chamber image in the subcostal view, and it's a good demonstration of what you'll see for a pericardial effusion or tamponade in this region. If this gets more and more significant, that it's affecting your the ventricular contractions, and you'll also note that those muscular contractive changes in that region. All right, so that being said, that leads us right into utilizing cardiac imaging in hypotension and shock. So typically your patients, you know much better than I, will be in significant distress at this point. And so you're going to want to tailor that GDE to get the information you need in the time frame that you need. So doing a full GDE may or may not be ideal at that point. So having all those tools in your toolbox and then determining which ones are going to give you the most high yield feedback in the time frame you feel like you have is going to be very important. So when you have a hypotensive shock patient, and you typically would like to complete the whole goal-directed echo because you know that you're going to get benefits of each different window and each different group of images that you can take. So we want to typically evaluate the left ventricular size and function, which we know is done most effectively through the apical views. Right ventricular size and function, again, that's in your apical views. We want to see if there's any pericardial effusion, which can be done in all of your views, but probably most effectively in that subxiphoid view. And then you want to see the intravascular volume status, which can be useful in basically all of your views, as well as taking a look at the IVC and even expanding the protocol out into the aorta. You also want to look at gross valvular abnormalities. And so this is something that can be accomplished really through your parasternal views as well as your apical views, but is somewhat limited in the subxiphoid views. So again, your goal-directed echo, if you can do the whole thing, that's fantastic. So that's going to give you the best results. If you feel like time is of the essence and you have to choose one or two, make sure you're choosing the image that's going to provide you with the most high yield information. Now, the goal-directed echo, like I mentioned, can be expanded into additional protocols, and the RUSH protocol is rapid ultrasound in shock. The SHOC protocol is sonography in hypotensive and cardiac arrest. You utilize the GDE with additional full body imaging to accomplish the goals of RUSH and SHOC. So those are just an extension of the GDE. Now, they can, again, according to the goals or the concerns of the practitioner, these two additional protocols can be expanded as necessary. So RUSH and SHOC utilizes the GDE, but they also can include evaluation of the lungs, looking for a pneumothorax, evaluation of the thorax, looking for maybe a hemothorax or pleural effusion or things like that. And then if they feel that perhaps pulmonary embolism could be the pathology causing the symptoms of the patient, they may even extend these procedures down into the lower extremities and do a very brief evaluation of maybe the femoral, the popliteal veins to look for major DVTs. So The combination of imaging of all of these areas can be utilized in an a la carte situation depending on the patient situation and suspected pathology. Another situation that you would expand this to would be an evaluation of the abdomen with perhaps an EFAST exam if you were concerned about a patient having trauma and having, or a ruptured aorta or an abdominal bleed or something like that. You can evaluate it, extend it to the kidneys to evaluate for kidney presence, function, any leaks out of the kidneys, or the same thing with the bladder. So your rush and your shock are just extensions of a GDE with a la carte selection of lungs, thorax, lower extremities, abdomen, aorta, kidneys, and bladder. So now how would you utilize this in a patient with hypovolemic shock? So with hypovolemic shock, you may utilize the following protocol to help evaluate beyond just the GDE. So first you might start with a GDE, looking at the cardiac component. So with a GDE, you would be evaluating the left ventricle and looking for hyperdynamic function. So if the patient has hypovolemic shock, they're going to have less blood in their system. That heart is going to try and pump harder to get the pressures that the body is intending. So you're going to have a hyperdynamic function of the left ventricle with end systolic effacement, meaning that the anterior and the posterior ventricular walls are coming all the way together because of that low pressure in the vascular system. In the right ventricle, it can appear normal to small size depending how significant the shock is. Then you can look for the thoracic component. So here you'd be evaluating to see if there's a blood loss into the thoracic area causing this hypovolemic shock. So here you're looking at the lungs and you're evaluating for A lines, the lack of any effusions that could be causing, that could demonstrate any other issues. So you're looking at the lung to make sure they're aerated and not filled with blood or fluid. A lines are going to tell you that would be a negative exam. The pleura, you're going to evaluate for those, the parietal and the visceral pleural sliding against one another. That's going to demonstrate that there is no pleural effusion. And then you can move on to the vascular component. So perhaps you're concerned that there is some sort of bleed causing this hypovolemia. So in this case, the IVC may appear collapsed. And even upon visualization over time, you're not going to see it go through those normal respiratory dilatations and reductions that you would be typically expecting. Additional components that can be evaluated as needed. So you can look for a AAA or maybe a ruptured AAA. So a quick long assessment down the aorta can help you evaluate for this, looking for any free fluid in the abdomen. Including an EFAST exam would also give you that same information. And then also looking for an aortic dissection. So these can be a little bit more difficult to evaluate, but when you're looking at your aorta, if you see a thin echogenic line and add blood flow to that aorta near that thin echogenic line, and you see that the aorta is being filled with blood in a false lumen, not in the true lumen, then that would be indicative of that aortic dissection. Now, if your patient is in cardiogenic shock, you're going to take a similar, you're going to have a similar start. So you would start with the cardiac images, and you're going to look for at the left ventricle. And with cardiogenic shock, you'll typically see reduced function in all views. So rather than that hyperdynamic function that you see in hypovolemic shock, here you're having reduced action from the the cardiac muscles. You're going to start to see dilated chambers, and you even, if it is affecting both the right and left side of the heart, then you're going to end up with right ventricular chamber dilatation as well. Now, as it backs up from left to right and then into the IVC, is you transition out of the cardiac area into the thoracic and abdominal area, you might see that you're starting to develop some B lines in the lungs because of pleural effusions developing because of the lack of ability to move that blood back from the lungs into the left atria. You might then if it's gone on long enough, you might then note that there's pleural effusions as that fluid begins to collect and accumulate in the pleural region. And then with the IVC is ultimately going to become distended, and you're not going to see those phasic changes with breathing because the heart is too congested to allow that venous blood back into it. Additional components to consider including would be evaluation for peritoneal fluid with the EFAST exam to see if that backing up of the vascular system into the abdomen has caused leakage of fluid into the peritoneal area. So your cardiogenic shock is going to look very different sonographically than your hypovolemic shock. So with the cardiogenic shock, you're going to have sort of a very expanded, congested heart and venous system, whereas with the hypovolemic, you're going to have a very collapsed, low pressure heart and venous system. Now, obstructive shock. This can be caused by a couple of different things, primarily tamponade, pulmonary embolisms, and pneumothorax. So if the patient has tamponade, they have this building up of fluid in a pericardial effusion, which is going to decrease the heart's ability to pump normally. So what you'll see is that the heart, where it's not able to pump, have good strong contractions, is going to start to have more small hyperdynamic contractions. As this happens, it's going to increase that pericardial effusion. The pericardial effusion can then cause right atrial systolic collapse because so much pressure is on that right atria. And then the left ventricular diastolic collapse because of the pressure on that ventricle during diastole. It can also result in a distended internal jugular vein, as that vein is no longer able to empty into this superior vena cava efficiently and then, get access to the heart. So with tamponade, that pressure around the heart is really going to cause it to pump less efficiently in backup, causing congestion to the proximal venous system. With the pulmonary embolism, often you're going to see dilatation of that right ventricle. So as that right ventricle tries to contract and force that blood in through the pulmonary artery to the lungs, because of that pulmonary embolism, that embolism is going to provide resistance to that blood flow, and it ultimately is going to provide congestion and a dilated right ventricle. And in the case of a dilated right ventricle, you may identify a D-shaped septum where the pressure increase in that right ventricle is significant enough that it's actually causing deviation of the interventricular septum. Again here, this is going to cause congestion of the right heart, which will then back up into the IVC. So you'll expect a distended IVC that does not demonstrate phasic changes. And sometimes if you choose to expand your exam into, say, the common femoral vein, the superficial femoral vein, and maybe the popliteal vein, you may find a DVT that was probably the origin of the pulmonary embolism causing these issues. And then a pneumothorax. So a pneumothorax could have caused that increased pressure on the heart due to the lung collapse. And with this, we're going to see changes in the heart, but we're really going to see the absent lung sliding. We're going to see A-line predominance and the barcode sign in M mode that we talked about in last week's lecture. Now, the only definitive diagnosis of a pneumothorax is when you see the expanded lung field in relationship to the pneumothorax. That's a guarantee that there is truly a pneumothorax there. So this pneumothorax then would have pressure on the heart and affect the heart's ability to provide flow to the rest of the body, and so that would therefore be obstructive shock. Then we can have distributive shock. So distributive shock can be caused by sepsis, anaphylaxis, or neurogenic in nature. So when we have distributive shock, you can see that depending on the cause of it is going to determine what it looks like. So with our left ventricular function in distributive shock, we can have hyperdynamic in a reaction of that left ventricle in cases especially like anaphylaxis, or we can have normal function here in cases like sepsis. With right ventricular function during distributive shock, we will often have a normal to a small size, depending, again, small if it's anaphylactic in nature, maybe normal if it's septic. Thorax, the thorax could have possible B lines, especially if it's perhaps septic in nature and you're having pleural infiltrates and things like that, then you could find B lines. If the infiltrates have gone on long enough and that congestion has been significant enough, then ultimately it'll probably result in a pleural effusion. And then with the abdomen, you may end up with possible collapsed IVC, especially in cases like anaphylaxis, or you can find possible ascites on an EFAST exam in multiple different causes of distributive shock. So those are all things there's no one prescription of what distributive shock is going to look like. It's just a way to analyze what's happening in the body while you figure out the cause of the shock. So how do you utilize ultrasound in cardiac arrest? So this can be really challenging because the purpose of utilizing ultrasound in cardiac arrest is to add information without disrupting the cardiopulmonary resuscitation at all. So point-of-care ultrasound in cardiac arrest, it is now supported by the American Heart Association. It causes logistic challenges due to ongoing CPR. So the larger your equipment is, the more people in the room, the more challenging this can be. It's recommended this is used in addition to ACLS to assess for rapidly correctable causes while CPR is in progress. So we know that we are really not going to fix anything with ultrasound, but sometimes if you can identify the pathology causing that the cardiac arrest, it allows us to address that cause and hopefully get that patient into a more stable state. It's also utilized to evaluate the efficiency of CPR in certain situations and help the physician make the determination of when CPR is no longer useful. So the role of POCUS in cardiac arrest are dependent on the underlying cardiac rhythm, and they use the 5 T's and the 5 H's for this. So we can evaluate for hypovolemia. Now, hypovolemia, remember, is going to appear as a hyperdynamic left ventricle with effacement of the anterior and posterior ventricular walls during systole. The hypoxia, we're not necessarily going to see this on ultrasound, but obviously this would be being monitored. It can evaluate, the patient could possibly be in acidosis, hyper or hypokalemia, and hypothermia. So really, when it comes to the 5 H's of cardiac arrest, we know that we're going to be most useful in identifying the hypovolemia and possibly the cause of hypoxia. The 5 T's would be tension pneumothorax, which we could help identify, tamponade, which would be very efficient at helping identify, toxins, which is not going to be our strong point, thrombosis or pulmonary embolism, which we just talked about how we could see, and then thrombosis from a myocardial infarction, which we could also be useful in helping evaluate. So in not all of these cases will be of any help, but in some of these, it can point the physician in a direction to treat something in particular that would help get that patient in a more stable state. So when do we use this? So during ventricular fibrillation or pulseless ventricular tachycardia, they recommend that you go directly to defibrillation and do not complete point-of-care ultrasound unless upon failure of defibrillation, then you can evaluate the heart by point-of-care ultrasound and look for occult ventricular fibrillation, which may have been mistaken for asystole. So sometimes it won't be picked up by on your EKG, and yet when you look and evaluate with ultrasound, you'll see that there is very, very small fibrillation occurring, and that could help the physician make the determination about where to continue on from there. And then if there's pulseless electrical activity and asystole, then we can utilize point-of-care ultrasound to identify the cause of the 5 H's and the 5 T's. So If we're seeing hypovolemia, we can predict that, or we can demonstrate that. If there's a tension pneumothorax, we can demonstrate that, tamponade, and pulmonary embolism. So we talked about how these things can be evaluated and how ultrasound can add to the full picture when patients are in these particular situations. So point of care ultrasound CPR guidance. Ultrasound allows us also to visualize the chambers during compression and evaluate for quality of compressions. When you're following general BLS standards, most of the time the compressions are actually occurring over the left ventricular outflow tract, which is not the most efficient area of compressions. So most reliably with transesophageal echo, once you get that the transesophageal transducer in there and start evaluating, you can see where the compressions are compressing the heart, and the sonographer can then direct the compressions to be moved over the site of maximal impulse to improve ventricular output while CPR is being administered. So most prevalent use of the point of care ultrasound arrest prognosis evaluation is the most prevalent use of cardiac arrest. So the biggest purpose of this is to evaluate whether the continuation of CPR is going to be effective or not. Now, cardiac standstill has an extremely poor prognosis. That means that when they're completing the CPR, they take a pulse check break and you evaluate the heart, you will see absolutely no movement. When that has occurred, they'll call that cardiac standstill. Now, don't be confused with if there's a little bit of valve flutter, as that could just be flow from one part of the heart to the other without contraction. And so make sure that you're not confusing that with true cardiac contraction. So you're watching the muscles here and making sure that there is no cardiac contraction. There's been very, very few survivors for patients that have been brought back after cardiac standstill, and of all of the survivors that are documented, none of them have been neurologically intact. However, pulseless patients with electrical activity and motion, whether it be very, very minor motion on ultrasound, have fared much better. And so knowing this simple finding would help a physician determine whether to continue with CPR in a particular instance or not. So the techniques that you're going to use in cardiac arrest CPR is, again, you're going to use that small footprint, low frequency transducer for the thoracic areas. And then if you choose to expand your protocol to evaluate for a DVT, then you'd switch to a linear high frequency transducer. And again, look in the common femoral, the superficial femoral, and the popliteal area for major DVT. Position the equipment to minimize the interference with the ACLS activities, but you have to be somewhere where it allows you for access to the necessary windows. So for most patients, the optimal position of the person providing point of care ultrasound is going to be at the patient's right hip. This is easy. This is the easiest place because it provides you the best access to the subxiphoid area. It also allows you to be able to reach over and look for the 4-chamber apical view, although with the patient in a supine position, this is not going to be optimal. So really, when you're scanning for cardiac arrest, that subxiphoid view is going to be your most efficient area of evaluation. Now, if you happen to be providing transesophageal echo services, then your position would be at the top of the bed towards the patient's head so that you could access their oral cavity more easily. It's important if you're scanning externally without the TEE that you're keeping your ultrasound gel away from the defibrillator pads, that you're imaging at the end of compressions and during pulse checks. So you want to demonstrate how efficient those compressions are while compressions are being provided, and then you want to see what the heart's doing on its own when no compressions are being provided. And then you want to complete clips during pulse checks as well as during compressions, and then if you complete a clip, you can review it once CPR resumes and evaluate to ensure that you whether there really is cardiac standstill or if there is any sort of contraction pattern. You can also use EMMO to demonstrate even the very most subtle contraction patterns or the lack thereof, which would be a useful documentation for the patient that you're choosing to discontinue CPR on. So there are some protocols and algorithms that can help physicians and practitioners get comfortable in the decision-making process. The focus on these are really going to be on high-yield etiologies like tamponade and pneumothorax that can be treated and hopefully cause immediate an immediate turnaround for the patient. Protocols should account for pathology of the arrest and be minimally interruptive. So here we have an algorithm produced by the text that we've been using, and you'll see that it kind of gives the physician some ideas of where to go depending on which finding they're finding. So a patient has a non-shockable rhythm, they are given epinephrine, and cardiac arrest ultrasound is suggested. And so while CPR is in process, you're going to be evaluating through the subcostal and 4-chamber view, looking for effusion in tamponade. If they find an effusion or tamponade, then the physician could progress to pericardiocentesis, which may relieve the pressure on that heart and get them back into normal function. If through that 4-chamber view they found inadequate left ventricular compression, they can suggest that the CPR provider repositions the hands and changes compression depth. Now, at the first rhythm check, again, they're going to be looking through that subcostal or that subxiphoid region at the 4-chamber view and look for ventricular fibrillation. If there is ventricular fibrillation, then it would be time to defibrillate. But if there's no ventricular fibrillation, that could lead to cardiac standstill and direct the physician's determination to continue CPR or not. If there's a pseudo PEA, evaluate the H's and T's as we talked about in the previous table and consider treating as profound shock. And if they continue on to CPR, you can progress to a secondary survey. So you can go to a FAST exam evaluating, or the EFAST exam, looking for free fluid in the chest or abdomen, assessing for pleural effusions, looking for where perhaps a bleed is coming from, and consider moving that patient to surgery if you do find that there is some sort of probable bleed cause for causing the cardiac arrest. If you evaluate the aorta in that FAST exam and you find that it's greater than 4 centimeters, consider a ruptured AAA and evaluate with the EFAST exam for any pericardial fluid, or excuse me, any peritoneal fluid or retroperitoneal fluid. And then if you see that that patient if you're identifying congestion in the lungs, congestion in the heart, then it might be time to go take a quick evaluation of those major veins, including the common femoral, the superficial femoral, and the popliteal, evaluating for a DVT, which would support your finding of, or your differential diagnosis of a pulmonary embolism. When you get the second rhythm check, then you can evaluate the pleura. Here you're looking for that pneumothorax that could be compressing the heart. If you see a pneumothorax, then it might be time for a thoracotomy to relieve that pressure. If you see in that subcostal view that you have a patient that has returned to normal cardiac rhythm, then you'd have post-cardiac care arrest. And if you find a patient that has cardiac standstill, then it would probably be time to terminate the resuscitation. So this is a fantastic algorithm to help walk through your processes before you're in that position, and hopefully will help you find some of this information useful and identify some ways in which you might want to implement it into your practice. So in summary, utilization of that goal-directed echo and extended protocols in critical care situations can drive physician decision-making and result in improved patient outcomes. The point-of-care ultrasound during cardiac arrest and hypotension can identify pathologies to be immediately addressed and demonstrate the need for even more thorough echocardiographic examination once that patient is stable. And then the protocols and algorithms provided can support a physician in the decision-making process utilizing point-of-care ultrasound results. Now, of course, from the physician end, these are a lot of different different decision makings and findings. What's going to be challenging is getting in there, getting comfortable, evaluating the different windows and the different being able to access the sonographic information you need just from scanning. So recognize that that may take some practice to get to that level, and but once you reach that, it can be a very important part of your treatment of your patients. So thank you so much for joining us again, and we look forward to your next lecture.